Thank you all for joining us on a Wednesday. I know we've got a lot of different time zones going on. So out east, you guys are, 8 o'clock, so it's getting a little late. West Coast, you guys might be driving home. So I'll try to describe the slides and read everything to you also if you got, AirPods in and you're listening or something like that. So we've had a couple questions throughout the week or last couple weeks that have come in to me through Preston, and hopefully tonight will kind of help explain some of those issues you're running into. Like Nicole said, this is an introduction to zirconia, so I'm not going to get too far off into the weeds tonight. But if you have any kind of like off in the weeds questions, please ask them. We'll talk about those at the end, and if there's anything more complicated, we can get into it then. So we'll go ahead and get started here. That's me, Matt Lucero. I'm in Denver, Colorado. If you are interested, you can follow me on Instagram. I try to post interesting stuff every now and then. I'm not a frequent poster, but every now and then I'll put up something that looks interesting. A little bit about me. If you don't know me, I went to Nova Southeastern University. Graduated a long time ago from there. Spent a good 4 years in South Florida. And then my goal at that time was to be kind of a do-it-all general dentist. So I moved to San Antonio, Texas, and I did an AEGD at the VA hospital down there. And that was a really great program. I really did learn how to do all those things, and then got out and started practicing and decided I didn't want to do any of those things. And then I went into public health and started seeing a lot more kiddos. And that's what motivated me to go back to residency. So after 5 years, I went back and I did my pediatric residency at OHSU in Portland, Oregon, and really loved it up there. But those long, wet winters kind of drove me back to Austin, where I practiced for a few years after that, and then moved up here to Denver, where I am currently. So that's a quick little history on me. Quick disclosure from NewSmile, they do provide financial support for these presentations. They provide me materials and help me kind of get some materials to put these cases together to show you all. There are some images from other fellow NewSmile clinicians, and I'll credit those when they pop up. But most of these cases are going to be mine. So if you have any questions on the particular cases, I can definitely explain those to you, since they're my cases. I like to start this intro lecture, really every lecture, but intro especially, with the AAPD guidelines, because I think these are like super important as a baseline for us to explain why we do these types of restorations. And if anyone ever questions us, or if an insurance company asks us why we did certain restorations, we can go back to these guidelines and reference these to help us out. But I think these are critically important, not to memorize, but to at least kind of have an understanding of. The first one, of course, is caries present on multiple surfaces. So, our typical interproximal caries with cervical decalcification. Yeah, we typically, especially under sedation or general anesthesia, want to do full coverage restorations. If the incisal edge is involved, I think for every incisor, if the incisal edge is involved, that's a crown, no matter what type of crown you decide to do. If you try to do, MDFLs or MIFLs and things like that, they just tend to fail a lot more frequently. If there's extensive cervical decalcification, so say you got 7 teeth that definitely need crowns in the posterior, and that 8th molar doesn't necessarily have everything, but you got some cervical decal in a high caries risk patient, maybe a crown's a good restoration for that tooth as well. If pulp therapy is indicated, this one for me isn't always. If we're in the pulp, I want a full coverage restoration. There are some people who will push the limits and try to do kind of big composites and things like that. And I guess depending on the age of the patient, it can be indicated. But for me, I always like to do a crown. If caries is minor and oral hygiene is very poor, or if the child's behavior makes moisture control really difficult, those are the last two. And those ones, that's for, younger patients who you're not able to get good isolation, kind of like a Hall crown indication, where, maybe they have a big occlusal on LRS, and you're not able to get isolation for a composite restoration. You put a crown on that, and that's a good indication for a crown as well. So composites have a high failure rate, like I mentioned. Composite resin strip crowns tend to have a high failure rate as well. And those are for a whole host of reasons, including incisal wear, chewing in habits. Kiddos are chewing on all sorts of toys and things when they're younger. Recurrent caries, which you'll start to see kind of in the cervical third frequently, demineralization in that same type of area. And then just the challenges in general with placing them, keeping these isolated, keeping heme under control, especially if you have a little bit of trauma from your burr. Now you got to go back and stop that before we can etch and bond. So there's just some challenges associated with, composite strip crowns that, when we get into zirconia, zirconia can kind of help alleviate. And there are articles on this that kind of back us up on this as well. This one was from Thailand, I believe. But this one says, resin strip crowns are deficient in function, especially with longer follow-up periods. And they found in this article that, over time, 52.8% of the resin strip crowns were unacceptable in function, which, after having practiced for years and years and years, you see these crowns come back and, initially they look really great. And then, 6 months, 12 months, 18 months down the road, you start seeing those little deficiencies in the crown and the chipping and the wear and all those sorts of things. And this is a photo from that article. And these are the same things that we see every day, all the chipping and the recurrent decay and the decalcification and just all the little things that tend to fail with these types of crowns. Here's another article that kind of backs up zirconia. And this one's out of the University of Washington. And this one states that, with aesthetic characteristics and high survival probabilities, zirconia crowns present a suitable alternative. And, for me, it's more than a suitable alternative. It's a better alternative. And they found 12-month survival rates at 93%, 24-month survival rates at 85%, and 36-month survival rates at 76%. And, for me, I think those percentages are even a little bit low. My 3 months or 36-month survival rate is higher than 76%, I hope. But in general, you're seeing that it's a much more successful restoration than like a resin strip crown. So let's get into zirconia crowns. We'll start with the advantages and disadvantages. So if you see off to the right there, New Smile zirconia crowns come in both light shade and an extra light shade. For me, I think light shade goes with the aesthetics of most of my patients. Some practitioners like a little bit brighter white shade, and that's what that extra light shade is. But the advantages of monolithic zirconia include best aesthetics. You could say resin strip crowns are up there as well, but the longevity kind of hurts the resin strip crowns. But with the long-term aesthetic restoration, zirconia is really as good as you can get. It's more soft tissue compatible. I'll show you a microscope image here in a little bit that shows how well tissue can be compatible with zirconia. There's no metal show. Obviously, there's no substructure like there is with the New Smile signature crown, like a veneered SSC. So you have more aesthetics circumferentially. They're highly, highly durable. So, in patients with crossbites or things like that, you're not going to have the wear and the chipping as you do with a veneered SSC. No child can bite hard enough to fracture a zirconia crown that's properly prepped. So these are incredibly durable crowns. There's no nickel for the few patients, very, very few patients that have a true nickel allergy. This is a good alternative to those crowns that have nickel in them. It's a full coverage restoration, of course. There's minimal chair time after practice, so your first zirconia crowns are probably going to take a little bit longer than they do after you've done, a few dozen of them. But after a few repetitions, and once you get some practice under your belt, this becomes a very repetitive procedure, and you can cut down the chair time quite a bit. They're autoclavable, and we'll talk about ways we can avoid autoclaving the white crowns. There are triangle crowns that we'll go over that are the ones we typically want to autoclave, and we'll find ways to avoid autoclaving the white crowns if we can. And for those of you who work in a hospital environment, like residents and folks that are working in hospitals full-time, there's no artifact in head and neck imaging. So, you get kiddos who are getting quite a bit of imaging or frequent imaging. If you're using stainless steel crowns, you may get a lot of artifact in those images, and zirconia can help you avoid that. There are some disadvantages to zirconia, of course, just like any restoration. There are pros and cons. You cannot crimp a zirconia crown, so you have to prep the tooth to fit in the crown. They're not like SSCs that you can adjust after you've prepped. You have to control saliva and hemorrhage. So really important, I'll show you here a few techniques to do that as well. There's a learning curve at the outset. And when we do these hands-on workshops with New Smile Restore courses, that's a really great way to get some hands-on time and get that learning curve out of the way before you get into your office. And then the cost involved. These crowns, I believe now, are $29.50. You typically get that back on the back end because they're a little bit more on the fee on the back end. But initially, there's a higher cost to get started with zirconia. So New Smile sizing is the Palmer notation. You can see on the lingual of each of the crowns, you'll have the tooth, which is the letter, so A, B, C, D, E. And then you'll have your size 3, and then R or L for right or left. There are narrow crowns as well, and I'll show you those here in just a second. But those Palmer notations on the lingual side, you can remove them because there are a few parents every now and then who, their kids have big cavities all over the place, and suddenly they're worried about the little black spot on the lingual of the tooth. So if you do have a parent who's going to be picky about the size, You can take a fine diamond or a white stone and you can get that size off. And here are those narrow crowns I was telling you about. I really like narrow Ds. I'm a big fan of narrow Ds. My kid actually has regular width E's and narrow Ds, and that's pretty much what I work with exclusively. So those of you who are trying to cut down on the number of crowns that you have to keep in stock, that is one way to do it. Most of the narrow Ds can fit on most teeth. In the worst case, you prep just a little bit more interproximally and you can get a narrow to fit. But narrows are really great for space loss. Any of those big interproximal decay cases where you have the E kind of leaning into the D, the narrows can kind of help you out in those situations. So here's that tissue attachment I was telling you about. Here's a scanning electron microscope image. There's lots and lots of studies that show that zirconia is biocompatible. Zirconia is used, there's zirconia implants, there's zirconia that's used in orthopedic procedures. So there's a long, long history of zirconia being biocompatible. And you'll see in cases when you get recalls how well the tissue responds. There's a case I'll show later on that shows a zirconia crown next to or adjacent to stainless steel crowns in the same patient. And you'll see the difference in the tissue response from one to the other. Actually, here it is right here. So you see here, the same patient, obviously, same mouth. You got stainless steel crowns on A and B, S and T, but you can see those like big red, plump, inflamed papilla between A and B. And if you go up to C, which is a zirconia crown there, you can see how nice pink stippled that gingiva is and the totally different tissue response that you're getting to the different material. And part of that is the biocompatibility of zirconia, but part of it also is the high polish of the zirconia crowns, and they just don't collect a biofilm. You don't get that much plaque accumulating on these zirconia crowns. And in this photo as well, if you look down on R, on the facial there, that's a class 5 composite, like a facial class 5. And you can see not the best polish of all time, but a little bit different tissue response even down there. But zirconia, you really, really see great recalls because of the biocompatibility. Yeah, just like I mentioned, chemically inert biocompatibility, good cell adhesion, and then no plaque biofilm accumulation. And there's a blown up version of that same patient. You can even see the biofilm on those SSCs. You can see the difference, that they just accumulate so much more plaque than the zirconia does. So what about strength? We know SSCs are really, really great. They're the kind of the gold standard for restorations in pediatric patients. Zirconia is even stronger. We don't really see perforations in zirconia. And like I mentioned earlier, the bite force that a child can create is not strong enough to fracture a zirconia crown. Where zirconia crowns are really strong is in that compressive strength. Where they lack strength is in expansion or kind of tensile strength, which is why it's so important when we do our prep that we prep the teeth appropriately and that we don't under prep and put any outward force on those zirconia crowns, because that's when you'll see fractures and failures. And I'll show you a case later on towards the end of the lecture here of a case where there was an under prep tooth and a patient came in with a fractured zirconia. But if you prep these teeth appropriately, you really shouldn't see any fractures. You can see it's way, way stronger than even natural enamel. And so the reason they can make these so strong, at least New Smile, is they have a process of manufacturing called injection molding. And the way it differs from other companies is that injection molding is basically the same as like when you were making gold crowns in dental school. You have a sprue and you have a mold basically, and they pump a liquid zirconia into those molds. And the benefits of that is that you can get a reproducible crown every single time. And that's why the tri-ang crowns that we'll talk about here momentarily work so well, is because they're exactly the same as the white crown that you're going to use to cement. You can get a lot more detail with injection molding as well. Because you're using that same mold and because you can put so much detail in it, you can get a really thin cervical margin, which on New Smile crowns is about 0.2 millimeters. And I'll show you on the intaglio surface, you can get kind of a mimic sandblasted appearance, which is going to give you more retention. The other benefit, of course, on the end of us as practitioners is that we save a little bit more money because of less waste. You don't have to do a CAD/CAM type of crown. There's less waste. You don't have to drill all that excess zirconia and be left with the crown. You're just using the injection molded zirconia, and that's what's going into your final crown. Versus a milled crown, which you guys might be more experienced with something like a CEREC type of a CAD/CAM situation. There's only so much detail you can get in a CAD/CAM type crown. So you'll see some of the competitors have kind of a thicker cervical margin, about a 0.5 millimeter or so. And then you can imagine you have these two little burrs. drilling a piece of zirconia over and over and over again. So your first crown's probably going to be a little bit more detailed than your last crown on those particular burrs before they switch them out again. So there can be a little bit more variability between the crowns. And like I mentioned, you get a lot more detail with injection molding, which conversely, you're going to get a lot less detail potentially with kind of a CAD/CAM technique. There is a benefit to the CAD/CAM. They can change their features and change the shapes of their crowns a little bit more easily. They just have to redo the design of that crown and they can adjust it. But overall, injection molding is really beneficial. And here's that intaglio surface I mentioned to you. Because that cast or that die of the crown is so detailed, you can get that little mimicked sandblasted appearance on the intaglio surface. So if we remember back in biomaterials class, the more surface area we have, the more retention we get on our crowns. And I'll show you the comparison to the other manufacturers here in a second. But you can see how much detail there is in that intaglio, and you're not going to have a lot of changes on the thickness of your crown. It's going to be pretty uniform throughout. And that leads to less compromise and less fracture of the crown as well. And here's that difference in the intaglios. You can see the new smiles on the left. The other three are just other manufacturers in no particular order. But you can see that the margin's a little bit thicker on those other crowns. And you can see kind of those grooves on those last two especially. They put these retention grooves on the intaglio surface as well. The problem with that, at least theoretically, in my mind, when you think back again to biomaterials, is that with a zirconia restoration or any type of restoration, you want to have a uniform thickness. You don't want to have all of these changes and variations on the thickness of your restoration. Any of those thin areas are potential weak points where there can be a fracture. So in general, we want all of our restorations to be pretty uniform in thickness, and that injection molding technique really gives us that with the new Smile ZRs. And here's a comparison of the marginal adaptation. That 0.2 millimeter margin is really helpful. It drops right into the sulcus for us, but also the shapes of the crowns are beneficial. You can see the new Smile Zirconia on the left-hand side has kind of a better emergence profile. At least, at first glance, it comes right out of the sulcus just like a tooth naturally does. Whereas as you move to the right and look at those other examples, you can see how they flare a little bit at the gingival margin, and you'll get a little bit more tissue impingement with those designs. Here's an example of that. This is the same tooth with two different manufacturers' crowns. You can see on the left, you get a little bit more blanching with that more flared cervical third of the crown, whereas the new Smile drops into the sulcus and you don't have that same type of blanching going on. Now, blanching isn't a terrible thing, right? Because all of our stainless steel crowns, for the most part, cause a little bit of blanching. But if we're trying to mimic what's naturally there, a more gradual and a more biologic emergence profile is usually best, at least in my opinion. So I mentioned the tri-ang crowns earlier and what the benefits are of those. One is that you're going to be autoclaving just that one crown because that's your tri-ang crown. That's the one you're going to get messy, and it avoids saliva and blood contamination of your final crown. For those of you who might have used other manufacturers, when you try your crown on, you get a bunch of blood and debris on the inside of your crown, and you have to get that stuff off. And so you hand that back to your assistant, and then they got to go in there with a little Q-tip or some sort of device to get that blood out of the intaglio surface of your crown. Whereas if you're just going to use a pink tri-ang crown, you hand it back to them. You know the size already because all those sizes are the same. They hand you back a white crown loaded with cement, and you go ahead and cement that right away. So that's one of the benefits. Eliminates extra steps. We'll talk about IvoClean in a second. That's your alternative to cleaning off the intaglio of the zirconia crown. But you can avoid all of that if you're just using a fresh crown straight from the box. They're autoclavable. And one of the benefits of that, at least, is that theoretically is you can get a little bit of shade change the more you autoclave a zirconia crown. It's not a ton, but you have some negligible shade change. So say you run one zirconia crown through the autoclave a couple of times, the other one is fresh from the box. You might see a little bit of shade difference if you've run that white one through the autoclave a few times. So if you've done E and F and they're a little bit off, you might have a noticeable change. They're quick and easy to use. Some people think that the tri-ang crowns take a little bit more time because you're using more crowns and you're using more supplies. But in my experience, it actually saves me a lot of time because we're not having to clean up crowns. We set that dirty one aside, have your fresh one ready to go, and you're done. And then it ensures successful results. With zirconia, if you contaminate it, there's phosphates, there's obviously blood and water and saliva and all those things that can affect your bond strength. If you're using a brand new fresh zirconia crown, you're not going to have any of those contaminants. Those of you who have been general dentists before or remember back, in dental school when you would deliver a zirconia crown, you get one crown back from the lab, right? So you get that crown, you try it on, you get it contaminated. Well, now you're supposed to clean that intaglio surface with something. You can either sandblast it, you can use IvoClean, you can use all sorts of different things to clean off the intaglio surface, but water and alcohol and things like that aren't going to get those contaminants off. You have to do some sort of specialized procedure to get that intaglio back to normal. And so if you're not doing that, you're going to lose a little bit of bond strength. So if you want, the fewest number of failures possible, use the least contaminated zirconia that you can. And I was mentioning IvoClean, that's about $40 per bottle. So if you're going to, be working out of multiple operatories, you're going to need to have a $40 bottle of IvoClean handy if you're not using trying crowns in each of those ops. And it's just another thing you have to keep track of. It's another step in the procedure. So my suggestion is try the trying crowns out. I bet you'll probably like them if you give them a try. One other benefit of these as well is if you break one, say you underprep a tooth and you're forcing a crown on a little bit more than you should and one breaks, I'd rather break a pink crown because they're $8. And the white crowns, I think that's an old slide. They're not $27.50. Inflation's getting all of us. I think they're $29.50 now. So $21.50 difference. I'd rather break the pink one than the white one. So use those as your trying crowns. They're a lot cheaper. So I talked about contamination. There are, like I mentioned, there are a few ways to get the contamination out if you're not using trying crowns. Zirconium oxide is a sandblaster, so that's going to get your bond strength back the most. I'm sorry, that's zirconium oxide, excuse me. That's just the normal intaglio surface here. Aluminum oxide is your sandblasted intaglio surface. That's how you're going to get the most bond strength back. But as you can see, if you use water or alcohol or phosphoric acid, you're not going to get really much bond strength back from that contamination. So you really have to use IvoClean in order to get that bond strength back if you're not using trying crowns. So here are the trying crowns in action. You can see you get them in, make sure that everything fits the way you want it to, make sure everything's aligned the way you want it to, and then you can get your white crowns and everything's going to fit and go exactly where you want it. So we talked about controlling hemorrhage as well. That's a really important part of doing zirconia. There are lots and lots of ways to control hemorrhage. Number one is doing pressure or moving to another treatment area. I like moving to another treatment area a little bit more than pressure. So I can prep the anteriors at the beginning of my case, move to the posterior, and while I'm working, that blood's clotting in the anterior, and we've got some hemostasis by the time we're ready to cement. The problem with pressure, in my mind, is that when we're squeezing the sulcus, we're closing that sulcus back up against the tooth. And when we seat our crown, we want to open that sulcus up again. And then you're going to potentially start that bleeding process all over again. So I'm not a huge fan of pressure for that reason. Pressure will stop the bleeding and you'll get hemostasis, but you're going to have to open that sulcus back up again. You can use superoxyl, ferric sulfate, hydrogen peroxide. I've never really used any of those. Ferric sulfate I don't love because you get that discoloration at the gingiva, and I like parents seeing everything nice and clean at the end and not asking me why things are brown or orange. So I'm not a big fan of ferric sulfate. Retraction cord, none of us are doing that. I don't think any of us are that big of go-getters. I like to do this interpapillary injection of vasoconstrictor, which is just a fancy word of saying, or a fancy way of saying local anesthetic. The epinephrine isn't exactly what I'm most concerned about. I really just want to get some blanching and push that blood out of the way momentarily. So I really like to use that. And then you can use Viscostat Clear, kind of same as ferric sulfate. You're just not going to get the staining of the tissue that you do with that ferric sulfate. But of those options, my favorite is just to use local anesthesia. And I'll show you that on the case here at the end of the lecture tonight. And what to use for cement. So I talked about how we do the prep, how we don't want to be under prepped, how we basically want that crown to be passive on the tooth after we're prepped. So we don't want that thing to lock on because then we're going to create some outward pressure and potentially fracture the crown, right? So we want that crown to be a little bit passive, meaning that our cement is really important. We need our cement to hold that crown on because we're not getting secondary mechanical retention. So when our crown seats, ideally, I like it just to move a little bit. I want that thing to be totally passive so I know I'm not going to fracture it. So the strength of our cement is critical. So there's lots and lots of options. There's glass ionomer, which in general isn't commonly recommended for zirconia because it kind of has the least retention of all of the cement options that we have. I do know people that use glass ionomer cement and they swear that it works. But in my mind, if there's other options that are going to hold that crown on better, I'm going to go with that option. But glass ionomer typically is not the most recommended zirconia cement. There's RMGI, which, Fujicem 2, Reliax, there's other manufacturers that make an RMGI as well. That's a really good option. I like RMGI in certain scenarios, especially in the posterior. If I can't get my curing light back there, I'll talk about Biosem in a little bit. That's a dual cure cement. But if I can't get my curing light back there, or if it's a little bit tight, then an RMGI works really well. I just got to hold those crowns in place while the RMGI sets up, which takes a couple minutes. There are resin cements as well, which have a little bit more bond strength. Downside to a resin cement is you have to keep things really, really well isolated because we have to etch and bond and go through the whole bonding protocol. And with our patients, that's usually not the easiest option for us. And then there's Biosem, which we'll go into a little bit more detail on. Biosem is a bioactive cement, similar to RMGI, very, very similar in handling characteristics. The biggest benefit to Biosem is that it's a dual cure. So you'll see in the case we do here later, I tack cure those crowns in place, clean up the excess, which is a little bit rubbery, so it's super easy to clean up, and then we do a final cure, and then we're done. So we're not waiting on RMGI to set up for 1 or 2 minutes. One thing to keep in mind with any cement that has resin in it, whether it's an RMGI, an actual resin cement, Biosem falls into this category too because there is a resin component to it, which is why it's light curable. But anytime you're using a cement with resin in it, we have to be cognizant of whether we're using any eugenol-based pulp medicament. So ZOE, anything like that, anything that has eugenol, that can affect the polymerization of our cement. So if we have a really big exposed area of eugenol, we may want to cover it up with something else, something like Neoliner, which is a liner product that NewSmile has, some sort of glass ionomer, or if you have Tempit, any of those materials will kind of negate that eugenol effect on the polymerization of your cement. So here's the instructions for use with Biosem. It's a little bit different than what you're used to if you're using an RMGI. You'll put your tip on, load up your crown about 2/3 to 3/4 of the way. You want to seat the crown and have a little collar of cement. You can see that little bit of excess right there. With Biosem, it's good to leave that because when we tack cure it, it's really easy to clean up. If you leave it thin and smear it, it's a little harder. But the one difference with Biosem is you have to wait about 10 to 20 seconds once you seat that crown. For most of us, it's not a big deal because we're aligning the crowns and we're fixing rotations and cants and things like that. But that 10 to 20 seconds allows that cement to start penetrating the dental tubules, and that's where you're going to get your bioactivity from. If we cure it too quickly, then we don't give that material a chance to get into those tubules. So that 10 to 20 seconds usually doesn't make too big of a difference because we're kind of goofing around with the crown anyway, but that allows that bioactivity to take place. Then we'll tack cure it in place. That'll kind of rubberize the material, allow us to clean it up. And depending on your curing light, it'll be 3 to 5 seconds or so, depending on, if you have a velo, a little bit less. If you have a little bit weaker light, maybe a little bit more. At this stage, we'll clean up our excess, like I mentioned. You want to hold that crown in place because we're not fully polymerized. But if we move the crown, we're going to break those polymers that we've already created. And then they're not going to be able to repolymerize. You got to hold everything in place at this stage. Then we'll allow that crown to sit for 60 seconds. During your cleanup, that 60 seconds is already happening. So we're not just sitting doing nothing typically for 60 seconds, but that cleanup will usually take up that whole minute or so. And then we'll give it a final cure, 10 to 15 seconds on all the surfaces, and then you're completed. That's it. So a couple little differences from what you might be used to, but it really simplifies the whole process. Here's some SEM images of Biosem after 24 and 72 hours. So the bioactivity is really just hydroxyapatite forming within the tubules. And if you don't do those little waiting steps that I described to you, you're not given the time for those little tags to start developing within the dental tubules. And because you waited a little bit, once you've done that light cure, there's already some within the tubules that are a little bit out of reach of your light. So they're going to continue penetrating over time. And at 72 hours, your bond strength is only going to continue to increase. And then one thing to be mindful of, and this happens, to all of us at some point or another, you're holding the crowns on, you think everything's aligned. There might be a little bit of excess cement on the facial of the crown covering your vision. The pads of your fingers might be covering the incisal edge a little bit. You don't see that it's canted one way or the other. But once you tack cure that crown into place, that's it. You got to go with it, or we got to remove the crown and start from scratch. You can't move them at that point, like I mentioned, because you're gonna break those polymers that have already developed. And then you're gonna have less bond strength because you're breaking the polymers. But yeah, you just got to make sure before you tack cure, make sure everything is exactly where you want it. So I really emphasize to people, take your time at that stage. You have a full minute and a half of working time. Don't rush it. If you need to move crowns, move them. But once you tack cure, you're done. And you can see there the alignment was off, and even on that incisal view, you can see it's rotated a little bit too. So case selection with zirconia. In general, and this doesn't apply for every patient, but in general, you can use a new Smile ZR anytime a standard SSC, pre-veneered, or strip crown would be used. The biggest exception is really like severe crowding, severe mesiodistal space loss, if you have really big rotations. One thing I've run into a couple times is if 7, 8, 9, and 10 are in, and you're trying to do a crown on a primary canine, sometimes the overlap from that lateral over your canine, if there's a little bit of minimal space in the anterior, you're going to have a tough time fitting that crown in between the lateral and your canine. So really be mindful if there's crowding or space loss on your patients, because that can make doing a zirconia really, really difficult. And you need to have adequate clinical crown. Like I mentioned, we're using cement to hold the crowns on exclusively. So if we don't have a whole lot of crown to bond to, we're not going to have a whole lot of bond strength. And then the ability to control hemorrhage. If you have a kiddo that's really inflamed, if you have a really young patient, 18, 24-month-old with severe early childhood caries, the teeth aren't like fully erupted, you kind of have that half eruption sort of thing where you're prepping really deep subgingivally, you're going to get a lot of hemorrhage. And those cases are really difficult to isolate. And then in general, if you're not seeing a kiddo under anesthesia or with sedation, make sure it's a cooperative patient, at least for your first few patients. Don't get yourself in over your head and get yourself in an uncomfortable situation. Pulp considerations. A lot of folks think that you need to pulp teeth that you're doing zirconias for. That is not the case. If you're doing the prep the way it's meant to be done and you're not over prepping, you shouldn't have to pulp a tooth just because you're doing zirconia. Of course, if you have decay to the pulp and you were going to do a pulp in anyway, then yeah, go ahead and do your pulp therapy. But the fact that you're doing a zirconia crown should not lead you to do a pulpotomy just for the sake of that zirconia crown. So here are a few zirconia cases that I've had over the years. This one was a neat one. This one was unilateral. She had decay between D and E, but not F and G. So we did a little bit of an asymmetric case, and I saw her about 2 years later. This was probably, I don't know, 6, 8 months ago. And everything looked great. Mom was happy. Kiddo was happy. You can see there was a little floss in her mouth because she had some new decay, and we got to treat her one more time. But the crowns looked really great. And she didn't have new decay in the front, which was awesome. We didn't have to do those other 2 teeth. And this was my assistant's child, so no pressure at all, right? Your assistant brings their kid in and they want you to do things aesthetically, and you're like, okay, yeah, we can do that. And in the back of your mind, you're like, all right, I hope this turns out great. But yeah, this was her kiddo. She got zirconia on E and F, and then we did Bioflex in the posterior. You can see those white crowns in the back. So she got the Cadillac service on that day. Here's another patient where we did upper incisors. We did C through H zirconia, and this was a lower incisor case as well. You can see N through Q on the bottom where zirconia is too. So that was a fun case to do as well. But you can really have a lot of fun with zirconia. These cases turn out really, really pretty. Your parents of the patients love them, and it's really nice to see them back because the tissue responds so well to these crowns. So we'll get into the anterior express prep technique. We'll kind of go step by step, and then I'll show you a whole case start to finish here in just a bit. And NewSmile can email you these in PDF form, the whole express prep. So if you want that, just send them a message and they'll send you an email with the PDF. But in general, there's 3 burrs that we use for this prep. There's a thicker black striped diamond, a football, and then a thinner green striped diamond, which is going to be your subgingival prep burr. Your first step is going to be incisal reduction. And depending on the length of the teeth of your patient, if they have wear, you may reduce this a little bit more. But if you have kind of a normal occlusion and a normal length tooth, you'll do about a 1mm depth cut on the incisal edge, and then you'll flatten that off. Then we'll do some depth cuts on the facial. And with this burr, the thickest part of the shank is about 1mm deep. So you'll get about 1mm of reduction if you use the full depth of this burr. So you'll make some depth cuts on the facial, as many or as few as you'd like. And then we'll do some interproximal slices. So same thing, you want to use the full depth of that burr because you want to get that full 1mm of reduction. If you go shallow on this step or on the depth cut step, you're going to have an under prep tooth, and you'll have to go back and do a whole bunch of adjustments to the prep. So if you go deep enough from the start, it makes the rest of the prep a lot easier. Then you'll connect all of those depth cuts and those interproximal slices that you made. I have that little blue line drawn there right at the free gingival margin because ideally you want to keep that as close to the gingival margin as you can. On that tooth, it's a little bit higher than I'd like. You want to make sure when you do your super gingival try-in that I'll show you here in a bit, that you're able to get that crown down to the gingiva and really get a feel for how your reduction is. Next step will be to take that football diamond, and you're going to reduce basically like the cingulum on the lingual side of that incisor. We'll do a little bit of rounding of those line angles on the mesial and distal just to round things out, but the bulk of your reduction is going to be that cingulum there. On bigger cingulums, you'll do a little more reduction. On smaller cingulums, a little bit less. So then you'll do your supragingival try-in, like I mentioned. And this is all just to make sure everything you've done prior to this is enough reduction. If you're under reduced at this stage, now you can take a couple steps back and readjust your prep without having things bloody and messy. This keeps everything pretty clean at the beginning of the prep. That way, if you make more adjustments, you're not dealing with a big mess and not being able to see what you're doing. So this try-in crown at this stage should get down to that little shoulder that you created. If everything's fitting and your crown has a little bit of passivity to it, now we can take that subgingival green stripe burr and put it about 1.5 millimeters to 2 millimeters subgingivally, and you're going to get rid of that entire shoulder and create a feather edge margin like we do on every other crown, like a stainless steel crown. Same exact type of finish. Main thing at this stage is keeping your burr with the parallel with the long axis of the tooth. Same with those earlier steps. You don't want to lean into the tooth. You want to let the taper of the burr do the taper of your prep for you. If you lean into it, that's when you start bringing those pulp horns into play. And that's when you start seeing those failures that people worry about with zirconia, which is why people think you need to pulp these teeth. So you don't want to do that. Don't lean your burr in, keep your burr vertical, keep it parallel with that long axis. And if you're under prepped, if you're not getting full seating of your crown, that's the area where your problem usually is. It's going to be in that gingival third or subgingival. If everything fit on your supragingival prep, then you know the rest of the problems from there on out are going to be subgingival. They're going to be either at the gingival margin or a little bit below that pregingival margin. Then we'll do a final try-in. This is just making sure everything's passive again, so you should have a little bit of wiggle on that crown. It should be able to seat all the way and be pretty passive on the tooth. And if it's not, take a step back and reduce a little bit more. Here's a good little rule of thumb that I have for crowns that are tipping. So if you're rocking, so if you put your crown on and you're getting a little bit of rock mesiodistally, what I picture is where's that hinge being created? So if you're rocking mesiodistally, you're tight on the facial and on the lingual of that prep. So that's where you need to focus additional reduction. That's where you're caught. So that's why the crown's rocking this way. Conversely, if it's going facial lingually, you're probably under prepped on the mesial or the distal. So that's a really good hint for trying crowns. If you're trying them on, things aren't fitting right, but you're getting a rock, that's giving you a lot of good information on what to fix on your prep or what to go back and correct. Here's that case I mentioned earlier that was under prepped. This kiddo came in with a fractured number E, and you can see on the facial of E there, it looks a little bit bulky. So that's what I assume. They probably got a little bit of a hairline fracture when they seated that crown. It looked fine when the patient left. And then over time and through function, they finally broke that piece of zirconia off. So he came in and we replaced it. There's a little bit of shade difference because it's a different manufacturer. But we have a new smile zirconia there for E, and then he had some new decay on C and H that we did zirconias on as well. But that's a good example of what can happen if you're under prepped. They may not fracture right away. You may feel a little click, but eventually that piece is going to come off and we'll have to replace it. So here's that anterior ZR case start to finish. This is a patient I saw, I don't know, a few months ago or so. Decay on D through G. We'll go through these steps here kind of one at a time. I like to try in my try-in crowns first, edge to edge or incisal to incisal to get the size. So that's what that first little step was there. But first step, like I mentioned, is going to be your depth cuts and then your incisal slices or your interproximal slices. And you're going to use that full depth of the burr. And I kind of make these all one step. I go depth cut, depth cut, depth cut. Then I go interproximal slice, and then connect them all together, kind of in one movement. So there are 3 steps, but we're doing them all together. And then we'll connect everything together into that shoulder that I described to you earlier. And this is just on the mesial distal and on the facial surfaces. We're going to go to the lingual here momentarily, but all we're doing is connecting those 3 surfaces into a shoulder and then rounding those line angles as we go. And we'll do the same thing on our central incisor. So that was just our lateral. We'll do our depth cuts here one at a time. This is a little different burr than what's in the new smile kit. So you'll notice I'm maybe not going the full depth of that particular burr, but we're still getting about 1 millimeter of a depth cut there. Then we'll do our interproximal slices and then right into connecting all of those. So those 3 steps are kind of all one step. And that can cut down on a lot of time for you too. So, you look at that prep sheet and you're like, man, that's a whole bunch of steps, but really it's just one right into the other. So we connect all those together and that's it for those first 3 steps. Now we'll take our football diamond and that's going to be our lingual reduction on that, mainly focusing on that cingulum. And while I'm back there, sometimes I'll go and touch up those line angles on the mesial and distal just to make everything round. You don't want any sharp corners on these preps. And you see there, we just took the cingulum off the lateral. Now we're going to go to our central, do the exact same thing while we're rounding everything together. Because sharp line angles and sharp point angles will impede the seating of these crowns as well. So you have to be really careful about that, keeping things smooth. So now here's our supragingival try-in. You can see we're all the way down to that shoulder. You can see we're kind of equigingival right at the gingival margin, like I mentioned earlier. The further you can seat that crown, the more information you're going to get about your prep. So we're passive there, so we're good to go to the next step, which is our subgingival reduction. And I like to start interproximally right where that papilla is, because there's a little bit more thickness of tissue, and you're less likely to cause too much trauma to the facial free gingival margin. So I like to start where the tissue is thickest, get into the sulcus, and then work my way around the tooth from there. And you can see here, we're going circumferentially. We're creating that feather edge all the way around the tooth this time. So we're incorporating the lingual of the tooth as well. And I don't really use a mirror here because I'm just using the feel of the burr, kind of like an explorer, and I'm just following the surface of the tooth all the way around. It just guides me to where I need to be. And I'm using it like an explorer as well, checking for any remaining shoulder, any remaining sharp areas, any remaining points. It's all kind of one motion, connecting everything together. And we're trying to limit trauma here as well. You're going to get bleeding. 100% you're going to get bleeding. You won't avoid that. But you want to limit the amount of trauma you create so that stopping the bleeding later is a whole lot easier. So we connect all that together. I like to go back and just round everything out like I mentioned. So we're hitting all those point angles, all those line angles, making sure there's nothing sharp remaining. Now we're going to do our final try-in. So you see how it's sitting right into the sulcus. That's what we want. We don't want it pinching the free gingival margin because you'll get inflammation. You'll get kids coming back with sore areas. And you'll see on this crown, it kind of is laying on the free gingival margin there. So I'm going to use my explorer to tease that tissue around the crown so that it drops into the sulcus for me. And now I got that little bit of passivity. You can see the crown moving slightly on the prep. And we know that we're not caught up or binding on the tooth at all. Here's my local anesthesia. You can see that little bit of blanching is all I'm looking for. I'm just pushing the blood out of that tissue momentarily. I don't need complete hemostasis. You'll see when we do our final cementation, we just need to beat the blood to the tooth. So we'll do a rinse, we'll do a little puff of air, we'll get all the blood off the tooth, and then as long as that cement within the crown beats that blood to the surface of the tooth, we're good to go. In the meantime, we also did some pulpotomies on E, F, and G. So you'll see there's little pulps there on the facials.
Hey, Matt, it is our 15-minute warning.
Oh, we're almost there. Thank you. So now we've got these loaded with cement. Again, I'm going to take my explorer, making sure that I'm not pinching that gingival margin. See, we're just kind of teasing the tissue over our crown there. We got that excess of cement, which is good. It means we don't have any voids within the crown, and it means we're going to have something to cure and peel off when we hit it with our light here in a moment. I like to just do E and F together first because I want my midline, I want my cants, I want all of my rotations to be taken care of. And if I'm juggling 4 crowns, it's a whole lot harder than juggling 2. So we just do 2 at a time. I like to do centrals. Some people like to do right and left. You can see here, I get my assistant, try to get them the most access you can while you're holding these crowns. You'll see in a moment here that on the distal of E, it's a little bit gooey right here. So I have my assistant come back one more time and have her tack that for me so it's a little bit more rubbery rather than gooey. But fingers get in the way, lips get in the way, blood gets in the way. So just take your time here. Don't rush. If something doesn't feel right, go back, cure it again. And even if you over cure, these crowns are so highly polished that even if you cure this stuff all the way, you can still get it off. It's not going to adhere to the surface of the crown because everything's pretty smooth. So don't worry too much about over curing. Just make sure that you got these tacked well in place. And you can see here, I'm holding the crowns with my fingers as I'm removing the cement. I'm keeping all of my pressure going towards the gingiva. That way I'm not pulling up on the crowns and potentially dislodging them. So just be extra, extra careful. We don't want to break those polymers that were created. So there's E and F in place. We'll get D and G in place, same way as we did E and F. A little bit of a cement collar. We know there's no voids. Now we've got G. And then we'll tack cure these in place as well. Get the tissue over the crown, all the same steps, everything's the same. Keep things systematic and then they're easy. Little tack cure here. And then we'll clean up just like we did with our centrals. Oops, sorry. I skipped the end here. Let me fast forward to the end. I'll show you the final case. So here's our final case after cleanup. You can see we don't have a whole lot of bleeding even post-operatively. So parents really like it. The kiddos come out looking really nice. There's not a big bloody mess because you've stopped most of the bleeding to begin with. You get a really nice tissue response, even immediately after the case. So zirconia is, I mean, parents love them. Post-op, you finish a case, parents are always nervous and anxious to begin with. And if their kiddos look great, they're happy too. So some final tips on zirconia: create your game plan for hemostasis. However you want to stop the bleeding, whatever you're comfortable with, go with that. But remember, the less trauma you create, the easier that second step is going to be. So be really mindful of the soft tissue as you're prepping. If your crowns aren't seating, reduce circumferentially in the gingival third, not the incisal third. Don't lean your prep in like this. Squeeze it in like this down in the gingival third. That's where you want to reduce. Only pulp if caries dictates, not just because you're doing a zirconia. Get a slight excess of cement. Get a little cement collar for easy cleanup. Take your time with adjusting these crowns. Don't rush. There's no rush, especially if you're in general anesthesia, if you're in the operating room. Take your time. Make sure that case ends up just the way you want it to. And then prepare guardians if the caries extent's unknown, if you don't know how much crowding there's going to be, if you weren't able to get x-rays, if you have any questions on whether things are going to fit, give yourself an out. Make sure parents are okay with an alternative. And that way you're not sweating and you're not panicking in the middle of a case. Not every case is a zirconia case. Most cases are, but there are a few that aren't. So be mindful of that. And that's it, y'all. We got some restore courses coming up I wanted to briefly mention. I'll be at Newburgh October 11th. There's Fort Lauderdale, Boston, and Nashville coming up. I do want to mention Newburgh is very cool. Newburgh's kind of like under the radar. I went to residency in Portland. Newburgh's kind of in the Willamette Valley right next to Portland. It's in the wine country. It is absolutely beautiful. So if you're not familiar with Newburgh, that's a very, very cool place. And it's going to be at the Allison Hotel, which is like a really, really nice spa hotel. It'll be a good getaway if you want to pop into Newburgh. Then we'll have Fort Lauderdale, Boston, and Nashville as well. That's my info. Thanks, y'all, for listening. If you want to reach out to me, you can email me there, or you can reach out on Instagram if you want to. I do want to briefly mention, this was an intro to zirconia. There is a Mastering Zirconia webinar coming up with Dr. David Harney. That is on Tuesday, October 14th. So he's going to go in a little bit more in depth on zirconia. So if you're interested in more, please check that out as well. Thanks, y'all.